Hello, my name is Dr. Ayesha Jameel. I'm a Clinical Research Fellow at Imperial College London. This talk is entitled Ultra-High Field MRI of the Thalamic Ventral Intermediate Nucleus to validate 3T anatomical and 3T tractography-based targeting for MR-guided focused ultrasound treatment of tremor. The ventral intermediate nucleus is the premier site for MR-guided focused ultrasound ablation in the treatment of tremor. Accurate targeting is crucial, as demonstrated in this picture taken from Krishna et al. The adjacent structures risk adverse effects, such as the ventral caudalis, a sensory nucleus, and the internal capsule, which contains motor tracts. The VIM cannot be directly visualised on current clinical scanners, and therefore the best way to target the VIM is under debate. The VIM is a thalamic motor nucleus with a key role in tremor. It relays information from the basal ganglia, cerebellum, and motor cortex. It lies anterolateral and inferior within the thalamus and measures approximately 3 by 5 by 8.5 millimeters. The most commonly used method to target the VIM is anatomical. This involves using stereotactic landmarks to infer VIM position, including the anterior commissure to posterior commissure line, the third ventricle, and the internal capsule. These preset geometric measurements are used for every patient. At our institution, we currently target the VIM 30% of the ACPC distance anterior to PC, 2 mm medial to IC, and 2 mm above the ACPC line. Anatomical targeting is widely used because it has good results. To date, there is good tremor suppression and an acceptable safety profile. It is quick, reproducible, and does not require any additional technology or expertise. However, it is not patient-specific, and as it doesn't consider any natural variation in neuroanatomy, there is no further safety information acquired. Tractography is an emerging method for VIM targeting based on diffusion tensor imaging. The technique is well described in the literature, and VIM position is inferred by locating 3 tracts: the pyramidal tract, the medial lemniscus, and the dentorubothalamic tract, as demonstrated in these pictures taken from a paper by Sammartino et al. Tractography is patient-specific. It demonstrates the motor tracts to avoid, improving safety. There has been a definite trend to incorporate tractography into MR-guided focused ultrasound. However, it is time-consuming, requires specific software and expertise. Many centres report it is difficult to integrate into current MR-guided focused ultrasound systems. Even with this technique, there is no direct visualization of the VIM. At our centre, we primarily target the VIM anatomically. We use tractography as a research tool and to review difficult cases. We wanted to explore the best method to target the VIM and how we could confirm the accuracy of our current thalamic targets. The VIM can be directly visualized on 7 Tesla MRI. It has a relatively low signal on susceptibility weighted imaging, distinct from its adjacent nuclei. This has been described by Najdanovska et al. We are fortunate to be part of the London Collaborative Network, which has an ultra-high field system, a Siemens Magnetome Terra 7T MRI scanner. The aims of this study were to compare the inferred position of the VIM by our institution's 3T anatomical and 3T tractography methods of targeting VIM, against the directly visualised location of VIM on the high-resolution 7T imaging, in order to demonstrate the accuracy or inaccuracy of our institution's current targeting methods. 3 healthy volunteers were scanned on 3T and 7T MRI, 2 female, 1 male, between 20 and 40 years old. For each healthy volunteer, the VIM was located on 3T MRI using the anatomical method and the tractography method, and on 7T MR by direct visualization. 3T imaging was performed on our current clinical scanner, a Siemens Magnetome Vario, using established clinical protocol including high-resolution volumes, additional axial EPI-based DTI sequences acquired in 30 directions, and DTI processing was performed on MRtrix version 3 with spherical deconvolution and probabilistic streamlines. VIM localization was performed on 3T imaging using our centre's anatomical method to give VIM A and our centre's tractography method to give VIM T, the details of which are described on this slide. 7T imaging was performed on the London Collaborative Locus Research Scanner, a Siemens Magnetome Terra. The protocol included high-resolution volumes, T2 star mapping and contrast-optimized SWI, with additional axial EPI-based DTI sequence acquired in 64 directions. Post-processing was done to optimize the contrast between the thalamic substructures, performed by a medical physicist. Brain extraction and segmentation was performed on FreeSurfer. Image registration was performed using FSL, and SWI contrast optimized images were created in MATLAB. 7T imaging was reviewed and VIM manually delineated on Philips Vue PAC station by a neuroradiologist on the SWI contrast optimized sequence. The VIM-S delineation was then verified by a second neuroradiologist. The medical physicist then segmented VIM-S in a 3D slicer and calculated the centre of mass. The VIM located by our institution's 3T anatomical method and the 3T tractography method, VIM-A and VIM-T, were co-registered and overlaid onto the VIM located on the 7T contrast optimized SWI sequence, VIM-S. Visual comparison and dye similarity correlation, or DICE coefficient, was performed to compare VIM volumes. For all 3 healthy volunteers, imaging was successfully acquired on 3T and 7T MRI, including DTI. The VIM-A, VIM-T and VIM-S were all successfully located. Here is the position of VIM-A for healthy volunteer 1, 2 and 3, represented as a pink triangle overlaid onto the 3T axial F-Katir images. Here is the diffusion tensor imaging for all 3 healthy volunteers, with the pyramidal tract in blue, the medial lemniscus in red, and the VIM-T represented as the yellow box. Here are the VIM-T results represented as a yellow box. For healthy volunteer 1 and 2, these are overlaid onto a 3T coronal MP2 rage, and for healthy volunteer 3 is a 3T coronal flare. Here is the VIM-S in green, delineated on the 7T axial SWI contrast optimized scan. VIM comparison was performed for each healthy volunteer. Imaging was co-registered and the VIM-A and VIM-T were overlaid onto VIM-S. In this example, you can see VIM-S delineated in green, the pyramidal tract in blue, and the medial lemniscus in red. VIM-A is represented as a pink triangle. VIM-T represented as a yellow box, with the centre of mass for VIM-T in a yellow cross. The centre of mass for VIM-S is represented as a green dot. You can see that VIM-A and the centre of mass for VIM-T and the centre of mass for VIM-S all overlap. And here is VIM comparison for healthy volunteer 1. You can see that VIM-A, VIM-T and VIM-S all overlap. On this comparison slide, for healthy volunteer 2, VIM-A lies anterior to VIM-S, but does overlap with VIM-T. VIM-T overlaps with all 3 structures, including the centre of mass for VIM-S. And for healthy volunteer 3, there is again good overlap between VIM-A, VIM-T and VIM-S. The DICE coefficient was calculated, which is a measure of overlap of volumes. VIM-S volume was compared to VIM-T volume, and the average DICE coefficient was 0.47, showing good overlap. The target coordinate for VIM-A and VIM-T were compared to the VIM-S centre of mass. The average distance for VIM-A and for VIM-T in all 3 planes, AP, ML and SI, was less than 1 mm, showing good agreement between the techniques. This distance is within the expected MR-guided focused ultrasound treatment lesion size. This study validates our centre's current clinical practice. Both the 3T anatomical and 3T tractography methods would target VIM-S in all healthy volunteers. As sonications are delivered as a sphere of energy and cover a larger region than depicted by VIM-A, for healthy volunteer 2, where the VIM-A lies anterior to VIM-S, in clinical practice, VIM-S would be sonicated. The study also demonstrates the utility of tractography, clearly showing the proximity of all VIMs to the PT and MR tracts. Although there was good correlation between VIM-A, VIM-T and VIM-S, both directly visualised and demonstrated by the DICE coefficient, no further statistical analysis was performed as the dataset was too small. Furthermore, the DICE coefficient was affected by our institution's methodology. Limitations of the study included a small sample size, the reliability of our neuroradiologists and medical physicists delineating the VIM on both 3T and 7T MRI, and the reliability of DTI itself. We would like to explore VIM targeting in an older cohort of healthy volunteers, more similar in age to our tremor patients, and consider lesion location in patients both pre and post-treatment. It would be interesting to consider the best part of the VIM to target, and also to use the 7T DTI to validate our 3T DTI. This study validates our institution's currently used 3T anatomical and tractography-based methods for inferring VIM position against the directly visualised position of VIM on 7T MRI, using susceptibility-weighted imaging, which is contrast optimised. Thus, providing reassurance that safe and effective VIM targeting can be performed on current clinical scanners, and that there is opportunity to optimise VIM targeting with the aid of ultra-high field MRI. Here are the references for this talk. Thank you for listening on behalf of our Focused Ultrasound team. Please do visit us in London.